Welcome to the Weekly Neurology Deep Dive. This program is produced by Amara Gabanini,
Hmm.
and I need to state clearly right at the start that this deep dive is strictly for educational purposes. It has absolutely no commercial goals,
Absolutely.
and it is strictly a summary. So listeners are highly recommended to read the full paper we're discussing today.
Definitely.
Today we are looking at the paper by Njitama and colleagues. It was published in Open Heart in August 2026, and it's titled Walking a Tightrope: The Safety and Efficacy of Oral Anticoagulants in Atrial Fibrillation Patients with Prior Intracranial Hemorrhage, a systematic review and meta-analysis.
It is a fundamentally important paper for our field.
I agree. And before we get into the weeds, we need to provide our initial practical summary for neurologists who are pressed for time.
I mean, that's crucial.
So in patients with atrial fibrillation and a history of intracranial hemorrhage, direct oral anticoagulants are associated with a significantly lower risk of recurrent intracranial hemorrhage compared to vitamin K antagonists.
Yeah.
Evidence for reducing ischemic stroke and mortality is less certain. These findings should inform shared decision-making, not definitive practice changes.
Exactly. The clinical dilemma driving this meta-analysis is it's one of the most challenging situations in cerebrovascular practice. I mean, over about 10% of intracranial hemorrhage cases are directly associated with oral anticoagulant use.
I see.
And anticoagulant-associated intracranial hemorrhage represents just a catastrophic complication of antithrombotic therapy. This is due to the resulting high mortality and the substantial burden of long-term neurological disability.
Right. It's devastating.
The major challenge here is that patients with a history of intracranial hemorrhage have been systematically excluded from the pivotal randomized controlled trials that originally compared direct oral anticoagulants to vitamin K antagonists.
So because those randomized controlled trials excluded this specific high-risk population, clinicians are just left to rely exclusively on observational data?
They are.
Neurologists must balance the prevention of severe thromboembolic events originating from the heart against the immediate, devastating risk of recurrent intracranial bleeding.
It's incredibly difficult.
It is. So let's look at the methodology. The paper details the inclusion of 5 retrospective nationwide cohort studies. These utilized massive healthcare databases from South Korea, Taiwan, and Denmark.
Yes.
The researchers pooled a combined total of exactly 16,376 patients.
That's a massive sample.
It really is. And the average follow-up duration ranged from 6 to 12 months across the various cohorts. But the reliance on administrative claims databases introduces a critical methodological question. How can we be certain these databases adequately capture vital clinical nuances? I mean, things like the initial severity of the bleed or the precise anatomical location of the hemorrhage?
We cannot be certain.
Yeah.
Because administrative databases fundamentally do not capture those specific clinical nuances.
I see.
They track diagnostic codes and billing information. So they completely lack detailed clinical information such as hemorrhage severity, specific hemorrhage location, hematoma volume, and the ongoing neurological status of the patient.
So they're just pulling codes.
Exactly. This structural limitation introduces residual confounding, which must contextualize all the subsequent findings we discussed today. Treatment allocation in these retrospective cohorts was determined entirely by individualized clinical decision-making rather than blinded randomization.
Meaning the doctors just chose what to prescribe.
Yes. And this dynamic makes confounding by indication completely unavoidable in this specific data set.
We really must explore exactly how confounding by indication manifests in this specific patient population. Because when doctors are making prescribing decisions, they're looking at the patient sitting in front of them, not just a list of billing codes.
Right. Clinicians likely prescribe specific blood thinners based on unmeasured clinical factors. Things like patient frailty, baseline functional status, fall risk, or specific neuroimaging characteristics.
Which aren't in the database.
It's exactly.
Yeah.
If a clinician perceives a patient as highly frail or at an extreme risk for a recurrent bleed, they might selectively choose a direct oral anticoagulant over a vitamin K antagonist based on perceived safety profiles. Because the databases never recorded these specific clinical variables, the statistical models mathematically cannot adjust for them.
I see.
This creates a scenario where the patients receiving direct oral anticoagulants might have inherently different baseline risk profiles than those receiving vitamin K antagonists, which skews the apparent safety or efficacy of the drugs.
So Because the baseline data lacked these critical neuroimaging and clinical nuances, the investigators relied strictly on hard clinical endpoints recorded in the administrative databases.
They had to.
Which brings us to the three primary outcomes analyzed in the paper.
Yes, let's go through them.
The first primary outcome is recurrent intracranial hemorrhage. Direct oral anticoagulants were associated with a significant reduction in risk, specifically a risk reduction of about 35% compared to vitamin K antagonists. Furthermore, there was no statistical heterogeneity across the 5 studies. The statistical heterogeneity was about 0%.
The absence of statistical heterogeneity is an incredibly important finding here. It indicates highly consistent results among the different national cohorts for this specific clinical outcome.
Even across different countries.
Exactly. Despite variations in healthcare systems between South Korea, Taiwan, and Denmark, that 35% risk reduction remained stable.
That's remarkable. So the second primary outcome analyzed is ischemic stroke. Direct oral anticoagulants significantly lowered the risk of ischemic stroke, demonstrating a risk reduction of about 20% compared to vitamin K antagonists. And similar to the first outcome, there was no statistical heterogeneity. The statistical heterogeneity for ischemic stroke was about 0% across the 4 specific studies that evaluated this thromboembolic endpoint.
Also highly consistent.
Yes. Now, the third primary outcome is all-cause mortality. Direct oral anticoagulants significantly reduced the risk of all-cause mortality by about 36%.
But this one is different.
It is. Unlike the first 2 outcomes, this finding came with substantial statistical heterogeneity. The statistical heterogeneity for the all-cause mortality endpoint was about 89%.
That is a remarkably high degree of statistical heterogeneity. It suggests marked variability in the patient populations, the underlying health status of the enrollees, or the specific methodologies among the 3 studies analyzing the mortality endpoint.
I see.
The baseline characteristics of the patients included in these administrative claims, databases show consistently high baseline thromboembolic and bleeding risks. Most of the included studies enrolled patients with non-valvular atrial fibrillation by explicitly excluding individuals with mechanical heart valves or moderate to severe mitral stenosis.
The timing of treatment initiation also varied considerably across the included data sets, which likely contributes to the complexity of the data.
It absolutely does.
The time from the initial intracranial hemorrhage to the resumption of oral anticoagulants ranged from an average of 6 weeks in one cohort to an average of over 3 years in another cohort.
That's a massive spread.
It really is. And the specific direct oral anticoagulants evaluated across the studies included dabigatran, rivaroxaban, and apixaban. The vitamin K antagonist evaluated in these cohorts was exclusively warfarin.
So, to manage the differences between patient groups, the investigators extracted the statistical model with the greatest degree of covariate adjustment when multiple estimates were available in the original studies. They prioritized analyses utilizing propensity score matching or inverse probability of treatment weighting. These specific methods attempt to minimize the measured confounding inherent to observational studies.
How do those work in this context?
Propensity score matching calculates the mathematical probability that a patient would receive a specific treatment based on observed baseline characteristics, and then matches patients with similar probabilities.
Got it.
Inverse probability of treatment weighting uses those exact probabilities to weight the cohort, creating a mathematical sample where the treatment assignment is statistically independent of the measured baseline covariance.
Okay, but despite the rigorous application of these statistical techniques, unmeasured confounding remains a major limitation across the entire meta-analysis.
It does.
Propensity score matching and inverse probability of treatment weighting effectively reduce measured confounding, but they mathematically cannot account for variables that are completely absent from the administrative databases, such as the hematoma volume.
Exactly. They can only adjust for what they can actually see in the data.
So, given the striking initial risk reductions, especially considering the reliance on administrative databases, the researchers rigorously stress-tested the data. They needed to ensure an outlier study was not inappropriately skewing the broad conclusions. The authors utilized leave one out analyses to test the durability of the findings.
The leave one out methodology involves sequentially omitting one study at a time and then recalculating the pooled effect from the remaining studies.
I see.
If the statistical significance vanishes when a single study is removed, the overall finding is considered highly fragile.
That makes sense.
The researchers also applied more conservative statistical adjustments, specifically the Hartung-Knapp-Siddick-Jonkman adjustment.
And what does that adjustment do differently?
The standard Drusimonian layered estimator used in typical random effects meta-analyses may underestimate between study variants when a meta-analysis includes a small number of studies.
Because they only had 5 studies.
Precisely. Because this analysis only included 5 studies, underestimating that variance could lead to falsely narrow confidence bounds. The Harto-Knapp-Siddick-Jonkman method incorporates uncertainty in the between-study variance estimate itself, generating wider and far more conservative statistical bounds to ensure the findings are truly robust.
And the researchers ran an additional overlap-adjusted analysis because the Taiwanese and South Korean databases might have contained duplicate patient records across different published studies. The national healthcare databases from those specific countries had overlapping enrollment periods in the selected publications. So which of the 3 primary outcomes actually survived these aggressive statistical stress tests?
The reduction in recurrent intracranial hemorrhage was the only clinical outcome that remained statistically significant across every single sensitivity analysis, including that strict overlap-adjusted test.
Wow, okay.
The pooled estimate remained consistent and statistically significant, regardless of which individual study was omitted during the leave one out analysis.
I see.
Conversely, the initial benefits reported for ischemic stroke and all-cause mortality lost their statistical significance when subjected to the more conservative adjustment models, or when specific individual studies were excluded from the calculations.
We really must break down exactly how that statistical significance was lost for the ischemic stroke and mortality outcomes. For ischemic stroke, the exclusion of a single specific study from South Korea rendered the entire pooled estimate not significant. And under the conservative Harto-Knapp-Siddick-Jonkman adjustment, the statistical bounds for both ischemic stroke and all-cause mortality widened considerably. They crossed the null value, rendering both outcomes definitively not significant.
Furthermore, the researchers calculated a prediction interval to estimate the specific range of treatment effects expected in a future comparable study.
Okay.
Recurrent intracranial hemorrhage was the only outcome with a prediction interval that excluded the null value, meaning future studies are highly likely to replicate this specific safety benefit.
That's a strong finding.
It is. During the leave one out analysis for all-cause mortality, the exclusion of a specific Taiwanese study resulted in the pooled estimate losing its statistical significance entirely.
So, knowing that only the recurrent intracranial hemorrhage outcome survived the rigorous methodological stress tests, it is absolutely essential to evaluate the overall quality of the underlying evidence before applying this directly to patient care.
We have to.
The researchers assessed the risk of bias, using the risk of bias, in non-randomized studies of interventions, version 2 tool. 4 of the 5 studies carried a serious overall risk of bias for the recurrent intracranial hemorrhage outcome.
This serious overall risk of bias was primarily driven by the residual confounding and confounding by indication we discussed earlier.
Right.
Additionally, some studies censored their follow-up data when patients switched treatments, without using inverse probability of censoring weights or marginal structural models.
Which introduces bias.
Exactly. This specific methodological choice increased the potential for informative censoring bias.
Let's clarify what informative censoring bias actually means in this setting.
Informative censoring bias occurs when the patients who drop out of a study or switch treatments have a fundamentally different risk of the outcome than those who remain on the original therapy.
I see.
If patients stop taking a direct oral anticoagulant because they experience minor bleeding and they are dropped from the safety analysis, the analysis falsely assumes their future risk of severe bleeding would have been identical to the patients who tolerated the drug perfectly.
That's a massive flaw.
It is.
Now, only one study, utilizing the Danish Stroke Registry, was judged to be at a moderate overall risk of bias rather than a serious risk of bias. That specific study partially addressed confounding by incorporating a stroke severity scale as a clinical proxy and by performing falsification outcome analyses.
A falsification outcome analysis involves testing the drug against a clinical outcome it should theoretically have absolutely zero effect on.
Like what?
If the statistical model shows the blood thinner is somehow preventing a completely unrelated condition, it serves as a massive red flag, indicating unresolved baseline confounding.
Oh, that makes sense.
By passing this falsification test, the Danish study demonstrated a more robust methodological framework. The researchers determined the formal certainty of evidence using the grading of recommendations assessment, development, and evaluation framework.
And what were the grades?
The certainty of evidence was definitively rated as moderate for recurrent intracranial hemorrhage, low for ischemic stroke, and very low for all-cause mortality.
The evidence was downgraded across these categories due to imprecision, residual confounding, and the inconsistency across the studies observed during the sensitivity analyses. So the clinical takeaway for neurologists is that direct oral anticoagulants appear to have a more predictable anticoagulant effect, shorter half-lives, and a substantially lower propensity for brain bleeding compared to vitamin K antagonists. These pharmacological characteristics were definitively demonstrated in the original pivotal randomized controlled trials of atrial fibrillation in the general population. However, these observational findings for patients with prior intracranial hemorrhage remain strictly hypothesis-generating.
They do. The findings address a critical evidence gap in a population systematically underrepresented in randomized controlled trials, but they do not establish definitive causality.
Right.
The researchers conducted this systematic review in strict accordance with the preferred reporting items for systematic reviews and meta-analyses 2020 statement.
I see.
The comprehensive electronic searches across PubMed, Scopus, and ScienceDirect yielded exactly 2,278 records. Following duplicate removal and rigorous abstract screening, 41 articles underwent full text review.
And they narrowed it down from there.
Ultimately, only the 5 retrospective nationwide cohort studies met the stringent eligibility criteria for this meta-analysis.
The primary reasons for excluding the other full-text reports included inappropriate study design, enrolled populations lacking a prior history of intracranial hemorrhage, or studies not directly comparing direct oral anticoagulants and vitamin K antagonists. This rigorous selection process highlights the severe scarcity of direct comparative data in this specific high-risk neurological population. When the investigators performed the final meta-analyses, they utilized the generic inverse variance method based strictly on logarithmically transformed hazard ratios and their associated standard errors.
We previously detailed the domains of the risk of bias in non-randomized studies of interventions tool regarding baseline confounding.
Yes, the confounding was serious.
The other specific methodological domains assessed by the researchers included bias due to selection of participants, classification of interventions, deviations from intended interventions, missing data, measurement of outcomes, and selection of the reported result.
And how did the studies fare in those domains?
Aside from the serious risk of bias, strictly due to confounding, the remaining domains were generally judged to be at low risk across the included studies.
This reflects appropriate participant selection within the structural constraints of the administrative databases, highly accurate classification of the anticoagulant prescriptions based directly on dispensing records, objective clinical outcome measurement based strictly on diagnostic codes, and fully transparent outcome reporting.
Precisely.
No study was judged to be at a critical risk of bias for any outcome, but importantly, no single study was judged to be at a low overall risk of bias for any outcome.
We must examine the specific patient counts and clinical classifications of the individual studies to further understand the exact data sources driving these findings.
Let's do that.
The researchers pulled data from the national databases of 3 distinct countries. The study by Lee and colleagues from South Korea enrolled exactly 5,712 patients. The study by Moon and colleagues, also from South Korea, enrolled exactly 4,964 patients.
Oh, I see.
The study by Tsai and colleagues from Taiwan included exactly 4,540 patients. The study by Lin and colleagues, also from Taiwan, included exactly 538 patients. Finally, the study by Nielsen and colleagues from Denmark included exactly 622 patients.
It's important to note that the Danish study by Nielsen and colleagues exclusively analyzed patients with primary spontaneous intracranial hemorrhage. The Taiwanese study by Lin and colleagues included all subtypes of intracranial hemorrhage, incorporating subarachnoid hemorrhage and various other etiologies.
The stark differences in hemorrhage classification across these individual studies contribute directly to the clinical heterogeneity of the pooled data, even when the strictly mathematical statistical heterogeneity for recurrent intracranial hemorrhage remained at about 0%. One specific study required a methodological adjustment prior to pooling the data. The study by Nielsen and colleagues reported risk ratios estimated using a pseudo-value approach combined with inverse probability of treatment weighting rather than reporting hazard ratios derived directly from standard Cox proportional hazards models.
So, because the event rates were below zero point zero 0.01 in certain sub-analyses, or rather, the overall event rates were quite low, and the follow-up period was strictly limited to 1 year, the investigators considered the reported risk ratio to be a valid mathematical approximation for pooling the data.
Exactly.
They validated this specific statistical assumption during the leave one out sensitivity analysis. Excluding the specific study by Nielsen and colleagues yielded completely similar pooled estimates for both ischemic stroke and recurrent intracranial hemorrhage.
That confirms that the different statistical measure did not inappropriately skew the overall meta-analysis results.
Right.
Treatment decisions for these patients must incorporate multidisciplinary clinical assessment, absolute thromboembolic risk, exact hemorrhage characteristics, total comorbidity burden, and distinct patient preferences.
It really requires a comprehensive approach.
Future research must prioritize individual patient data meta-analyses to formally rule out cohort overlap, mandate strict stratification by hemorrhage subtype and precise anatomical location, and execute prospective or target trial emulation studies in this high-risk population.
We return to our practical summary for daily clinical practice. In patients with atrial fibrillation and a history of intracranial hemorrhage, direct oral anticoagulants offer a significantly safer profile regarding recurrent intracranial hemorrhage compared to vitamin K antagonists. However, benefits regarding ischemic stroke and overall survival are not as firmly established, meaning treatment requires highly individualized clinical judgment rather than sweeping guideline changes.
Absolutely.
Considering the main limitation of this meta-analysis was the lack of neuroimaging details and administrative claims data, how might the future integration of automated imaging analysis with these massive national databases finally reveal exactly which subtypes of intracranial hemorrhage stand to benefit the absolute most from direct oral anticoagulants?